So neurofibromatosis, how often do we see them? So quickly I'll go through what is NF, what are the ocular features, and when there is ocular involvement, why do we need to follow them, and how often do we see them? So NF is a rasopathy. So rasopathy is a group of condition which you get because of involvement at different levels in the RAS and MAPK pathway. This is a pathway involved in intracellular signaling. So you have a stimulus which comes to the cell, and then there has to be certain processes in the cell which relay the information to the nucleus. So in this intracellular signaling pathway, there are several genes, and involvement of them can give to this condition called rasopathies, which involve things like Noonan's, Legius, craniofacial cutaneous syndromes, and NF as well. So it's a genetic condition. We can divide it into two types. Type 1 is due to problems with chromosome 17, and type 2 due to mutations chromosome 22. Often there'll be a family history in half of them, so half of them can be first presentations. And it's not an uncommon condition. It's 1 in 3,000. So the gene which codes for neurofibrin is affected in NF, and as I said, it regulates the RAS MAPK intracellular signaling pathway. Now, neurofibromin actually regulates cell growth. So if there is a defect in neurofibrin, you get massive cell growth. So that's why you get the neurofibromas and you get all these masses. So as ophthalmologists, we play an important role in the NF-MDT because amongst the diagnostic criteria for NF, you got lesion nodules, you got optic pathway gliomas, and you got your plexiform neurofibromas. They form part of the diagnostic criteria for diagnosing someone with NF. Now, lesion nodules are just markers, but the OPGs are sight-threatening, and the plexiforms can be unsightly, and of course, they can affect vision in a child. So you get lesion nodules in the iris, but if you image the choroid, you often see choroidal nodules. And there are papers saying that probably choroidal nodules are a more sensitive indicator of NF than lesion nodules, because lesion nodules take a bit time to appear. It's with lesion nodules, it's an age thing. So if you see a young child, maybe 40% or 50% of them will have lesion nodules. But if you see someone who's around 20, mostly it's coming up to 100%, they'll have lesion nodules. So choroidal nodules have also been used as a more sensitive marker for diagnosing NF. So coming to optic pathway gliomas, they are grade 1 astrocytomas. They're generally benign, and around 15 to 20% of the NF1 patients will have OPG. The risk of vision loss is greatest under 6 years of age, and this is important to bear in mind because based on these things we decide why do we need to follow them up and how often do we follow them up. Around a third to half can cause morbidity, which could be either visual or endocrine, but they have a very variable nature of progression, and it also depends upon the location. So the post-chiasmal ones will be the ones which are more affected, they affect vision to a greater extent as compared to the pre-chiasmal gliomas. And the best modality to image this is MR scans. So when should we treat them? They're very slow-growing tumors. Okay? So when should we treat them? Well, you should monitor them radiologically if you know a child has OPG. However, just radiological progression is not a criteria for treatment. There has to be clinical worsening as well. And the reason for that is several studies have shown that you intervene, you give chemotherapy, just based on radiological progression, you don't get much visual improvement. The treatment for this, as I mentioned, is chemotherapy. With chemotherapy, around you can say 3/4 of them get stabilized or better. But that means around 25% still worsen despite chemotherapy. The lesions may increase slightly in size in between the sort of scanning periods, and then they sort of stabilize for a prolonged period of time. Mild to subtle impairment of vision generally remains stable for a prolonged interval, so it's really difficult to know when should we actually intervene and treat them. And it is like a chronic disease. You basically keep the tumor under control. They may never go. You sort of burn the tumor out. You sort of switch the process off. So how do you monitor them? Well, if you're looking for optic nerve functions, you check your usual visual acuity, color vision, pupils, fields, VEPs. But I think the most important thing is OCT. With the advent of OCT technology and easy availability now, This is the best modality in my clinic to monitor this. So we're mainly looking at the peripapillary retinal nerve fiber layer, and we're looking at the ganglion cell layer thickness. And as Jane mentioned, we have a workshop on multimodal imaging, and we'll be presenting several cases of NF and how OCT helped us. So, in terms of follow-up, no rights or wrongs. In my clinic, this is what I do. So if I'm seeing them purely from the screening point of view, or whether I'm seeing them because they have a known OPG. So if you're screening them, and if they're between 0 to 4 years, I see them every 6 months. Reason being, as I said, the visual loss with the potential OPG is worse in under 6. And plus this age group is notorious. I mean, you can't reliably check their vision. So from one visit to the other, their vision may vary. So you have to see them again and again. And the young ones, you can't get onto OCT. So that's why I'd like to see them every 6 months. Between 4 and 8, I see them annually if it's just for screening. And if they're over 8 and they have a normal intellect, I discharge them to the community optometry. Whereas if they have learning difficulties and children do not cooperate very well in the community, so I keep them in the clinic till they turn 16 and I just hand them over to the adult side. But if they have a known OPG, which has been found on scanning, and if their vision is affected, so they are on chemotherapy, I see them every 3 months. If the vision is not affected, but they have a known OPG, so till they're 6, I see them every 3 months, and over that I see them every 6 monthly. So just a quick slide on NF type 2. It's a genetic defect localized to chromosome 22. It's an adult onset disease. So the features are you get cataracts, you get facial palsy, you can get oculomotor palsy, and you get an ERM and a combined hematoma of the retina and RPE. So why do we see them? Well, we see them for screening purposes because it is an adult onset disease. Your vestibular schwannomas and your facial palsies will come on at a later age, but you may have the cataract, you can have ERM, and a good ocular examination may pick it up. So your management changes for that child. So you can feed into the MDT whether this child has NF2 or not, and it helps in planning their management. Thank you.